Greetings. I'm going to discuss regarding maximizing the diagnostic power of blood cultures to enhance the sepsis management. I'm Dr. Neha Gupta, infectious diseases specialist, empowering my patients to overcome their infections and lead a healthy first life. And today, the focus is on maximizing diagnostic power of blood cultures. And in my opinion, there are 7 key ways of doing so. The first one is understanding the need for blood cultures. Why is it important to discuss blood cultures? Why does it matter? Because blood cultures are the gold standard for diagnosis of sepsis. Sepsis, a life-threatening condition, affects millions of people globally each year. And a diagnostic delay results in a therapeutic delay, which results in increasing mortality. Every hour delay increases mortality by 7%. And there is a very famous infectious diseases wisdom which says you can't treat what you don't know and you won't know without cultures. In fact, blood cultures matter. Culture negative severe sepsis has 70% greater odds of dying as compared to the culture positive cases. And this is from a healthcare study which was done almost a decade back in the USA. So blood cultures are a need. They are the gold standard in diagnosis of bloodstream infections. It helps in diagnosis of true infections, detects the resistant pathogen, provides the drug susceptibility, and helps in guiding the targeted therapy, which has a huge impact on the antimicrobial stewardship programs, helps in understanding the local antibiogram, which helps in the empirical choice of the antibiotic therapy, and also by identifying certain bacteria like MRSA, CRE, flavobacterium. It can help in a focused infection control practices. This is a famous study which was published in IDSA 2013 regarding the ID specialist intervention, improving outcomes for patients with severe infections. And it showed that an early ID involvement in syndromes like septic shock, bacteremia, osteomyelitis, septic arthritis, endocarditis, line-related infections, vascular device infections, prosthetic joint infections were associated with a shorter overall stay, a shorter ICU stay, a lower Medicare payment for the index stay, as well as lower Medicare payment for 30 days post-index stay discharge. So, interestingly, these syndromes have positive cultures more often as compared to the other syndromes. So indirectly, probably positive blood culture had this impact. In fact, we are living in this world of molecular diagnostic assays where we want to know what is the mechanism of resistance so that we can optimize our antibiotic therapy better. But all these molecular assays, they are dependent upon the cultures. So the focus has to be on blood cultures for maximizing the utility of the molecular diagnostic assays as well. And how do we do this? So we can do it with various ways. After understanding the need for it, it is the timing of the blood cultures, which is very important. When should we obtain the blood cultures? So I will explain it with the help of this patient who is 56-year-old gentleman post CABG. He had the sudden onset leukocytosis. The count jumped up to 30,000 and he had a new onset hypotension and in fact had a cardiac arrest. He was on cefoperazone sulbactam. The CPR was done, he was revived. At this point, there were differential diagnoses like the line-related infections, VAP, UTI, post-op surgical site infections. These were the differential diagnoses which were considered. Now, as a part of the management, the blood cultures were drawn and the central line was changed immediately. And then subsequently, the polymyxin B-based combination therapy was initiated. Now, since the blood cultures were drawn, and they were drawn before starting the antibiotic therapy, the new antibiotic, the blood cultures grew carbapenem-resistant Klebsiella pneumoniae, and the DTP, which is differential time to positivity, was more than 12 hours. So this one test gave us many answers. It helped us in the diagnosis of this new onset hypotension, that it identified that it is the Klebsiella with the help of isolating the bacteria from the blood as well as from the peripheral line, and a DTP more than 12 hours, indicating that it is a Klebsiella. And with this, obviously, since it's a Klebsiella, we can use polymyxin B based therapy, or in today's era, of course, go for novel BLB-like combination therapy. So in sepsis, in diagnostics, it's timing, which is everything. Antibiotics, even if they are resistant, they can suppress the bacterial growth, leading to false negatives, depending upon how effectively the antibiotic is achieving levels at the site of infection. So it's always important to collect the blood cultures before starting antibiotic. Even if a patient presents to the emergency, collect the blood cultures and then start the antibiotic therapy, because the blood culture bottles are available in the emergency then and there, whereas the antibiotics anyways will take a little more while to arrive. The target has to be that the blood culture should be collected within 1 hour of the clinical recognition of the fever or the sepsis. Now, this third most important key for improving the power of blood cultures is to send the blood cultures in adequate volume. The volume has to be right. More blood is associated with a higher yield. And one of the common pitfalls for false negative blood cultures is the low volume. It's the underfilling of the bottles or even single bottles being taken. So if there is only one blood culture bottle which is sent, then the sensitivity of isolating the bacteria is hardly 10 to 15%. Whereas if one set, which is one aerobic and one anaerobic blood culture bottle is being taken, then the blood culture sensitivity increases to 65%. And this increases to 80% if there are two sets which are being drawn. So if there is a patient who is having a central line, then draw one set from the central line and one set from the peripheral percutaneous puncher. So single puncher and two bottles should be drawn. It should not be one bottle from one hand and another bottle from the other hand. And of course, if you're sending three sets, that increases the sensitivity to close to 95%. And usually, three sets are preferred in patients with sepsis, ICU patients, or even in patients where we're suspecting infective endocarditis. Now, infective endocarditis is one of the infectious diseases syndromes where three sets of blood cultures have been recommended for long. This helps us in understanding the microbiological profile or the bacteria which are causing the infective endocarditis. And this has an impact on our choice of antibiotic therapy, how we choose antibiotics in patients with heart infections. So here, this is our observational study of 32 patients, which was done between 2013 and 15 and presented in SITSCON 2015 in Delhi. The most common bacteria isolated were VGS, Enterococci. We also had MSSA, MRSA, Pseudomonas, Candida, infective endocarditis, Scedosporium, and of course, cons and Klebsiella pneumoniae. And based on the understanding of the microbiological profile, we were able to extrapolate it and use it for optimizing the treatment for patients with infective endocarditis. So here is this table. The red bars indicate antibiotics which were used before the infectious diseases consultation, and the blue bar indicate the antibiotics used after the ID consultation. And following the ID consultation, a change in the antibiotics was done in 25 out of the 32 patients, and de-escalation of the broad spectrum meropenem as well as the PLB-like combination to ampicillin and ampicillin combination was done in 12 patients, which also resulted in reduction of the healthcare cost. It almost saved 3 lakhs of the patient by doing this change based on the understanding of the microbiological profile, which obviously the information we receive is from the blood cultures. Now, another way for maximizing the diagnostic power of blood cultures is by following a strict aseptic technique when we are drawing the blood cultures. Now, let's see what is the impact of contaminations in the blood culture. Now, this is a 55-year-old gentleman who was posted for a dual valve replacement because of his mitral stenosis and aortic stenosis. And now, just before the surgery, there is a call from the lab that there is a gram-positive cocci which is growing. Now, with this, everybody is scared and the surgery gets postponed and he started on teicoplanin. Subsequently, we have this GPC being isolated and identified as Staphylococcus hemolyticus. Now, the Staphylococcus hemolyticus is a coagulase negative staphylococcus, which is a common skin colonizer or a contaminant. And because the patient was afebrile and this is a single positive blood culture, we discontinued teicoplanin and the patient went ahead with the surgery the next day. So it is when there is a contamination, it has an impact on unnecessary treatment and the cost, and many a times the faith on blood culture may be lost. So to maximize the power and the diagnostic power of blood cultures, it's important that we reduce the contamination, and this will eventually avoid unnecessarily antibiotics and will decrease the length of stay as well as the adverse events related to the drug reactions as well. Now, when there is a cons which is isolated, when is it significant? So remember that when you have only one single positive culture with coagulase negative staphylococcus like Staphylococcus hemolyticus or Staphylococcus epidermidis, then it's very likely a contamination. It's a common skin colonizer. And in fact, the standard of care is to have the cons positivity to less than 2.5% of the all positive blood cultures. This is the standard of care. If it is high, then it's a red sign. Either it indicates wrong contamination or wrong sample collections or a higher incidence of CVC related bacteremia or line related infections. So when is cons significant? It is when it is isolated in multiple cultures, especially if there is processes like a line repeated in isolations. 3 out of 3 sets is very likely 100% a pathogen. And there is also a newer concept that if it is getting isolated in less than 16 hours and there are two positive blood cultures, then probably it should be considered as a significant pathogen. So for improving the power of blood cultures, we must focus on clean collection and quick transport to the lab. The transport should be ideally within 2 hours of the collection and reduce the contamination rates by clean antisepsis with 0.5% chlorhexidine or 70% alcohol, clean the top of the bottles, and nowadays we definitely have these vacuum which can be used directly. So there is so that the contamination can be avoided. There is no need to change the needle. The blood cultures should be inoculated first, and remember, it should never be refrigerated. Should be transported quickly to the lab. And there is a misconception that the results of blood cultures is going to be available only after 5 days. It is not so. Most of the pathogens, like close to 80% of the pathogens, grow within the first 24 hours. So it's important that we send the blood cultures before we start antibiotic therapy. And remember that the ideal time to collect the blood culture has no correlation with the fever spike. Collect the samples, but before antibiotics is the most important key. Now, another important key would be to create accessibility for the blood cultures for the clinicians. Now, let's take this example here. This was a patient who's a young boy who had presented to us with fever. He was also having diarrhea for more than 2 weeks. It was watery, it was loose motions, and he said that he has received antibiotics, but there was no relief. And then clinically, we felt that this is a small bowel diarrhea, of course, with the predominant loose motions, but with fever, there is always a possibility of salmonella, which is typhoid, and E. coli bacteremia, E. coli small bowel diarrhea. So in this patient, I told him that, if I can write antibiotics, but before I start, I think it's better we do at least one blood culture. And even if you don't want to do 2 bottles, at least do 1 bottle. And he luckily agreed. So I started him on antibiotic, and the next day we get this result from our microbiology friend who says that yes, there is a positive blood culture which is growing, and the time to positivity is just 13 hours. So within 13 hours, there was a GNB which was growing, and it was identified as Salmonella typhi. So this obviously changed the management. It's just one infectious diseases consultation and one positive blood culture, the test done before antibiotics, which then subsequently sorted the patient, and he had complete resolution of the fever. So it's important to send the right test in the right patient at the right time. And this is diagnostic stewardship, which is possible when we have blood cultures facility available in the clinics. So if I had told this patient that you go somewhere else, get the blood culture done, so the chances of this patient accepting that I need to get a blood culture done would be definitely less, because the blood culture was available in the clinic, in the place. That's why the acceptance was higher as well. And it definitely helped us in arriving at the diagnosis. Another important aspect is early and frequent communication with the lab, because this can really be one of the game changers, and this was a game changer in the diagnosis of this mysterious bone infection, which in fact he is my mamaji, who had a bone infection in Riva, and he started having fever initially, did telemedicine consultation, and because there was this normal WBC count but elevated biomarkers and not very significant forearm pain. Initially, we thought that this could be salmonella. We requested him to get the blood cultures done, but it was not available in Riva per se. So empirically, he was started on cefixime. The fever subsided, but the forearm pain persisted, and that's when he came to us and in our clinic, and the MRI revealed that there is a radial bone osteomyelitis with joint effusion. The blood cultures were sent again, and the right elbow effusion diagnostic tap was done. Now the initial cultures came out to be negative, but the GI panel which was done showed that there is strep pneumoniae which is isolated. Now because this is isolated, we had requested the orthopedician to do the debridement, but the patient and relatives wanted to continue with the conservative therapy, and hence antibiotics were continued. But on these antibiotics, the fever persisted, and that's when we repeated the blood cultures, which grew GNB. And my microbiology friend was told me, ma'am, this is growing GNB now, and we immediately did the multi-TOF, which revealed that this is Burkholderia. It was identified as Burkholderia pseudomyeli. So this very complex Burkholderia pseudomyeli osteomyelitis in an immunocompetent patient could be identified because of the positive blood culture. Again, showing the impact and the importance of sending the samples whenever we can. We were fortunate to present this case in Darwin, Australia. We were invited to present this in the 10th World Melioidosis Congress, and the blood cultures definitely have an impact on the antimicrobial stewardship and the healthcare cost, and understanding this again definitely can maximize the power of the blood cultures. So this is a patient who is a gentleman with AML, and he was on induction chemotherapy. He had developed fever. He had received prior fluconazole, but currently was on posaconazole prophylaxis, and an ID reference was given. He was started on meropenem and polymyxin B, but there was no response to it. And on day 2, he started having rashes. So the difference was here when he started having rashes and he was not responding. The blood cultures peeped positive, and they grew this gram-positive Candida. So this is candidemia in a patient who's neutropenic with sepsis. And again, because of this positive blood culture, we were able to modify the treatment. The antifungals echinocandins were initiated, and the meropenem and polymyxin B, the broad spectrum antibiotics, were discontinued. So this definitely saves the cost of the patient. The cost of not sending the blood cultures is huge, because it can result in empirical broad spectrum overuse of the antibiotics, resulting in antimicrobial resistance explosion. It can miss unusual bugs like Burkholderia, Candida, MTR bugs, as well as the MRSA. And inappropriate treatment results in longer stay, higher mortality. Every missed culture is a missed opportunity to treat the patient appropriately. Another patient who had presented to us with pyrexia of unknown origin for a long period of time, for almost more than 8 months, and he was having normal WBC count. There was a mild elevation in the globulins, and he had similar complaints in the family members. There was no lymphadenopathy or hepatosplenomegaly as such on clinical examination. Now, in this patient who is having PUO, what should we do? Should we perform serological test, blood cultures, antigen detection, PET-CT scan? What should we do? 1 and 2, 4 and 2. Should we do a PET-CT because this patient is having PUO? So what he told me is that his guy is having abortions. What does it indicate? It indicates that there is a possibility of brucella, and we sent the test for the brucella agglutination as well as for the blood cultures. So the brucella agglutination was positive, and the blood cultures grew brucella. So here, instead of performing the PET-CT scan, which can be as expensive as 30,000, we did simple blood cultures, which cost hardly 900 rupees, and also this brucella agglutination test, and arrived at the diagnosis. So the wisdom for choosing the appropriate test will come by listening to the patient. As his famous quote from Sir William Osler mentions, that listen to your patient, he is telling you the diagnosis. And ultimately, it is the collaboration across specialties, collaboration between physicians, microbiologists, nurses, phlebotomists, which is very essential for improving the diagnostic power of the blood cultures. Success will arrive by working together with a long-term strategy. And with this, we welcome you all to SITSCon 2025. Thank you so much.